should move up to the front. Yes, let's move up to the front so we can talk. How about that?
You're fine. Thank you for coming up. I appreciate you sitting up front. Thank you. Yeah. So I am actually very happy for the microphone. I think I'm allergic to the state of Arizona because I have lost my voice. I don't know what's going on. So can you hear me okay with my scratchy voice? Okay, perfect. So well, welcome, and thanks for sticking around Friday morning. But my name's Carrie Harvey. I'm an associate professor of emergency medicine at the University of Michigan. And I'm also boarded in critical care. And over the years, because of where I work, have just developed this niche interest in palliative care. And really my favorite thing to teach is this, which is how to talk to people with serious illness. And so in the next 20 minutes, we'll sort of review, this isn't like a heavy like literature review-based presentation. This is meant to be very pragmatic for sort of a framework on guiding discussions and responding to emotion with empathy. And of course, my hope is that you'll gain confidence with leading these conversations yourself and then starting to teach these skills to other people. So I have no disclosures. So this quote is from an older blog post, but I just feel like it rings so true. I bet some of you may have walked into a difficult conversation just hoping that those perfect words would just magically come to you. And I am guilty of this. There's a particularly rough encounter from my residency that I literally still think about with that like visceral feeling of shame in my gut because I know I could have done a better job. And I remember just like beating myself up and thinking if only I was like naturally better at this, I would just have known what to say. And I think what I've learned over the last 10 to 12 years is that first, no one is naturally good at having these conversations, but skillful communication is not magic. It's a learned skill. It's the same way you learn how to do a lumbar puncture and intubate somebody and chart on shift. It's just a skill you practice and get better at. And so those people that you observe and you think, they're so good at this and I wish I could sound and look like them, I promise you that they have learn these skills and deliberately practice them so that they can face these hard conversations head on. And I believe that all of you can learn these same skills, not all of it in 20 minutes, but I hope our time today ignites this desire to improve your own skills. Because I know that you're all kind, empathetic people, and I want you to have the words to express that to your patients. Okay, so here are our objectives today. Just a few slides on the literature around communication skills training. We're going to talk about how to construct a headline when you deliver serious news to a patient or family, and then I want you to walk away with a couple of phrases on how to respond empathetically to emotion. So this first study, just a few years old, I think unsurprisingly, showed what a lot of us experience all the time, which is that the deck is stacked against us in the emergency department. These conversations are hard even in the best of circumstances, and so this study, in polling their ED providers, noted that acuity and lack of a established relationship is the biggest barriers to having good conversations in the ED. This study collected about 300 surveys from EM residents and found that trainees do not feel comfortable in many difficult communication scenarios and that communication skills training is lacking in their residency. So now we've identified that we're not really set up for success in the ED as it is, and then we ask our trainees to have many of these conversations despite little or no formal skills training. But I will say all hope is not lost. This was a study that implemented a 4-hour training session that utilized professional actors to role play and train more than 1,000 EM providers. And they found that the participants were able to acquire sort of concrete serious illness communication skills and were committed to using these skills in clinical practice. So this is really cool to me because it's like a train the trainer course, right? It can have a really broad reach as one person then goes on and trains many more. So when thinking about the difficult conversations that we may have in the ER, I always think about breaking them up into sort of 3 big buckets. So there's death notification, serious illness notification, and then a goals of care conversation. don't know what happened there. We won't be reviewing goals of care strategies today just because of time constraints, but if people do have interest, I can go in the hallway after this. There we go, okay. So what is it about these conversations that is so hard and induces all this anxiety in us? Research has shown that we are afraid of eliciting an emotional reaction. We are afraid of being blamed for the bad news, and we're afraid of our own emotions coming out. And I think this leads to people withholding information or sugarcoating it. And honestly, that just causes confusions for patients and families and is not helpful. And so I think all that fear and that milieu that you're swirling in leads to these two consistent stuck points in a conversation, which is crafting a headline, because you have to distill down sometimes very complex medical facts into a clear sentence that patients and families can understand. And then the second is recognizing emotion and responding to it with empathy. So we're going to go through these two things for the duration of this talk. So starting with the headline, I want you to think of it as the major piece of new information plus the implication of it. It also needs to be concise. I usually stick to 2, maybe 3 sentences, and completely free of medical jargon. If you miss the mark with any of those things, you risk confusing your patient or family. And headlines are actually very tricky. I, again, have learned over the years because of some not so great encounters I've had. I actually write down my headline and go into the hallway and say it out loud before I go into a room or call somebody. It is, remember the quote, intuition is a poor substitute. So I don't rely on my intuition anymore and hope that I'm gonna go in and this perfect headline's gonna come to me magically. So I wanna practice this with some cases. These are all actual cases of mine over the years. This first case was from my second shift ever as an attending. It was a young man brought in by EMS unresponsive and receiving CPR. And he was from out of state. We didn't even have an ID at the beginning, so we don't know any medical history. And ultimately, after about an hour, we stopped resuscitation, and the patient was pronounced dead. And so his mom was contacted and knows that her son is very sick in the ER, but doesn't know what else happens. We do not rely on our social workers to break the news of a death. I do not feel that that's morally a good thing. So I knew I had to call her, and I was really starting to stress out about what I was gonna say. You may be feeling some of that same anxiety about delivering news like this. Maybe you're even hoping those words will magically come to you, but we're gonna do deliberate practice. We're gonna craft a headline before we call his mom. And so I want you to take 30 seconds. You can think it in your head, you can type it in your notes app, whatever, but I want you to think, what is the 1 to 2 sentences, the exact words that I'm gonna say to his mom? Not a vague feeling, the exact words. So just take a moment to think. So I'm gonna share, I don't know if this is exactly what I said, but with the benefit of hindsight, this is something that I would try. When John arrived to the ER, he was not breathing and his heart was not beating, and we did everything we could to try and revive him, but John has died. I use the D word, so the headline's in blue. I use the D word. I don't think that you need to explain the implication of dying. I think people understand that, so this is a little caveat of what I said about the headline. But you want to ensure that the headline's the last thing you say, because after it, you are silent. In silence, you're going to want to keep talking. Silence feels real bad, but it can be really powerful, really in any emotionally charged conversation, but particularly after a headline, because you need and expect an emotional reaction to occur, and you need the space for that. So I always tell people to sit with the discomfort, and if it helps, of course, remember that no matter how I'm feeling, it is infinitely less bad than the person I just broke this news to. I also want to just introduce the concept of a warning shot. This is a sentence that you say before the headline, and so it functions as a natural transition from any prior conversation into your headline. And I think it sort of gently prepares people that the news coming is serious. And I've used the same one for a decade, so it's up on the screen. It just feels very natural to me now, and I never am fumbling for words in the moment, but unfortunately I have serious news, I'm afraid I have bad news, some sort of phrasing like that, then your headline, then your silence. So I'm going to switch gears a little bit, and let's do a serious news delivery, a little bit different than a death notification. So this patient is a 56-year-old man, and he comes in with some really what seems like a viral illness. But he's newly on oxygen, and so far all of his testing for causes of acute hypoxic respiratory failure are negative. And I was starting to think about, was I going to have to scan him? And then the lab called me and said that he probably has AML, which is, I was not expecting that. I know the patient is not expecting that. So now my differential is shifting. I have to very quickly consult hematology. They're going to come down. I have to get into the room before them and let the patient know about this. So again, my heart rate's picking up, my palms are starting to get a little sweaty, and I'm starting to think about, oh my gosh, how am I going to break this news? So same as before. Take 30 seconds. Think about how you would take all this medical information, distill it down into a few sentences. So again, I'm going to start with my warning shot. I'm afraid I have bad news. I ask permission that it's okay to share first, but then your warning shot. So this was, again, something similar to my headline. Based on your symptoms today, I was worried that you might have a viral infection or maybe even a pneumonia. Your tests don't show, though, that you have either of those. Unfortunately, your blood work today shows that you have leukemia. And then you're quiet. Going back real quick, this is another one where I think, to be concise, the the information and the implication are the same, because I think most people know what the word leukemia means. But you could have said, unfortunately, your white blood cell count is dangerously high, which means you have leukemia, right? So you always have to have both parts of that headline, the news and the implication. Okay, so remember, the silence again is to allow space for that emotional reaction to occur. And you should always expect emotion after delivering serious news, right? I used to think if someone was crying, it's because I did a bad job. And now I recognize they're crying because they heard what I said. I actually get more worried if there's no emotional reaction. I worry that my headline was not clear and they are not understanding the gravity of the situation. So if you're expecting emotion, you have to have ways to respond to it. And again, we're not going to rely on intuition and hope that those words magically come to us. We're instead going to use another skill set that is called NURSE. So this is not anything I made up. This is in the literature. NURSE is an acronym for various empathetic statements that you can use to acknowledge a patient's emotion, and it stands for naming, understanding, respecting, supporting, exploring. And then there's a sixth category that we call I wish statements. And NURSE statements are really powerful because they allow you to accept a patient's response without necessarily agreeing with it. And we'll go through some examples of that in a moment. But it really boils down to, if a patient is showing me emotion, having this emotional reaction, I think to myself, I'm hearing a lot of emotion, I'm seeing a lot of emotion, I need to nurse my patient, I need to use a NURSE statement with my patient. So you're doing that active listening and you're picking up on some emotional cues, and you're going to want to try a NURSE statement. So this is just a few examples. This is not comprehensive or meant to be memorized or anything. It's just to give you some ideas and allow you to pick some that might feel, genuine and organic to you, things you can imagine yourself saying in real life. So my go-to for everything is I wish I had better news. When I can think of nothing to say and, someone's angry and yelling at me and there's a vacuum above my head and I'm stressing out internally, I use my I wish statement. I like that one because it's true. It's very easy for me to say, I do wish I had better news, and we were not having the conversation we're having. In general, you want to use one NURSE statement at a time and then pause. And one statement may be enough for someone to process their emotion and sort of de-escalate. But sometimes you might have to use a couple in a row. But you don't want to string a bunch of them together. It sort of loses the impact if you use a naming statement, a respecting statement, a supporting statement, and an I wish statement in one sentence. And then what you definitely don't want to do is add on medical facts. I wish we had a treatment to cure your cancer. Maybe we could reach out to the Mayo Clinic and look and see if they have a clinical trial, like if you wanted, right? Like I'm not addressing someone's emotion when I say that, and then I immediately backtrack into medical facts. You really just say your nurse statement, and then you're silent. So last case, last few slides. We're gonna use a third case. So we have an elderly woman who has pretty advanced dementia. She lives in an extended care facility, and she comes in, she's very ill. She gets intubated, she's on pressors, she has a surgical abdomen with no surgical intervention offered, and so she is dying. And her brother is the DPOA, and you have to call him and update him about this. So again, take just a moment. I'm gonna take one more sip of my coffee. Think about your headline. What are you gonna tell the brother when you call? So again, I'm going to start with my warning shot. I'm going to try and distill down someone in multi-system organ failure into a very succinct headline. So your sister is very ill. She's on life support. Her organs are failing, and her intestines have twisted on themselves, which is making her extremely sick. Unfortunately, there is no treatment that can fix this damage to her body, and I'm worried she has only minutes to hours to live. All right, so the headline again, the information is, this is a terminal event, phrased differently, and the implication is that she is actively dying and has not much time left. And then I'm silent. So let's say, after you deliver this news, her brother starts crying and says, "What do you mean? That's impossible." How would you respond to that? I think we often have an inclination to answer a question like this with more facts because we worry that a response like this means that they didn't understand the headline and we just want him to know how sick his sister is. But if I just told someone their loved one is dying and they start crying, that is an overt emotion in my opinion. And I'm just going to respond to that emotion with a nurse statement and a nurse statement only. So I might say something like, "I wish things were different. I wish I had better news. I can't imagine how overwhelming this news is." And then you pause and you wait for them to respond back. If it de-escalates things, maybe you can move the conversation forward. If they are still very emotional, you might have to use another nurse statement. Let's say you get something like this. So you're just gonna give up on her? I hear that. I hear maybe there's some fear driving that question, maybe some anger, maybe some guilt. I don't know, but I don't think they're really asking me a yes/no question, right? Like I think there's emotion behind that. So again, I'm going to answer it with a nurse statement. So these are some examples of like a support statement. We will be here for her and for you. Our team is here to help you through this. Explore statement. Can you tell me more what's worrying you? Maybe you get some nugget of information that allows you to address the root of that question. Okay. Isn't there another antibiotic you can try? So this is an example, I think, of what I call a masked emotion, which is often given to you in the form of a cognitive question or statement. 95% chance her brother is not interested in a nuanced discussion about broad-spectrum antibiotics, right? Like this question is being driven by an emotion. So I would recommend then that you answer it with a nurse statement. And it can feel weird at first, like you're just like straight up ignoring someone's direct question, but in my opinion, ignoring an emotion can be harmful. Giving an additional nurse statement when it wasn't actually needed is not really harmful. So when I hear again a question like this, after I've just told someone that their loved one is dying, I'm assuming there's emotion driving this. So I'm gonna respond with a nurse statement and only a nurse statement. "Oh, I wish I had a treatment that would cure her. I can't imagine how shocking this news must be. This is an impossible situation." Right? All right, 2 more slides and then I'm done. Okay, this is a tricky one. You never want to argue faith. But many people will say they don't know how to respond to this because they still feel this like moral responsibility to explain how sick somebody is. So I still believe the best way to respond to something like this is with a nurse statement. Remember, I said they're very powerful because they allow you to accept a patient's response without necessarily agreeing with it. So I often say things like this: I hope that for you too, or for her too. I really admire your faith. This last explore question, probably better if someone had a longer prognosis than minutes to hours, but an advanced cancer patient who's hoping for a miracle who might have months to live, I think it's worth exploring that sometimes. Maybe their definition of a miracle is actually different than mine. Okay, so we're just gonna end with one more quote, which I think reminds us that our words do matter, but also recognize that we are doing hard things, and you can give yourself some grace as you continue to learn these skills and do your deliberate practice, and then start teaching them to others. And I'll stop there. That's my email if anybody wants to reach out. I know that we got started a little bit late and we're probably over by a minute or two, but I'm okay? Okay. If anyone has any questions, then I'm happy to take them.